Hello, my name is Roger Henderson, I'm a GP and I also co-host the GPnotebook study groups. Welcome again to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now in this episode, I want to walk you through the condition known as Chondromalacia patella, often abbreviated as CMP, and this entity has been recognised for well over a century. Early clinicians observed unusual softening and degeneration on the underside of the patella, and the term chondromalacia, derived from the Greek words for cartilage and softening, was eventually adopted to describe this process. Now, although the terminology has remained, our understanding of this condition has grown enormously, especially as we've learned more about the biomechanics of the patellofemoral joint. So essentially, chondromalacia patella is a disorder of the patellar articular cartilage. And instead of the firm, glossy, bluish-white surface we expect from healthy hyaline cartilage, the involved cartilage gradually becomes softer, swollen, and more vulnerable to mechanical damage. Over time, these initial subtle changes may progress towards fissuring and, in advanced cases, fragmentation. But in early stages, the process often begins along the medial facet or slightly inferior to it, though it may spread depending on underlying mechanical stresses. Now, women and active young people are disproportionately affected, and this is where I need to mention something called the Q angle. And this is the angle formed between the lateral line of the pull of the quadriceps and the patella, measured from the centre of the anterior superior iliac spine to the tibial tuberosity. Now, the average Q angle for men is 14 degrees, and in women 17 degrees due to a broader pelvis. And a higher mean Q angle value is said to contribute to patellofemoral pain. So those engaged in running or jumping sports, typically younger adults or people who frequently subject their patellofemoral joints to stress through things like repetitive stair climbing or kneeling, are at higher risk for developing chondromalacia. Now, the causes of CMP are rarely singular, and rather this condition tends to emerge from a blend of mechanical, anatomical, and biological factors. One of the most important concepts in understanding why CMP develops is the idea of patellar tracking. The patella doesn't simply glide straight up and down. Its movement depends on limb alignment, quadriceps balance, and the anatomy of the trochlear groove. Now, when the patella is subjected to excessive lateralizing forces, it tends to be pulled outward during knee flexion, and that repeated lateral pressure concentrates force on a limited area of cartilage and predisposes it to wear. I think we should also consider the role of foot mechanics here. So excessive pronation or valgus alignment can shift loads further up the kinetic chain, and in doing so increase lateral patellofemoral pressure. And even something as seemingly harmless as frequently wearing high heels can alter joint mechanics enough to contribute to the problem. And some patients can also present with what's termed miserable malalignment symptom, which is a constellation of femoral anteversion, genu valgum, and external tibial torsion or pronated feet, all of which amplify maltracking forces and give us miserable malalignment syndrome. Now, muscle function is another crucial part of the story here, because weakness in the vastus medialis obliquus or in the hip stabilizers, for example, can diminish the medial pull that normally keeps our patella centered in the trochlea. Trauma, whether direct impact to the patella, prolonged immobilization, or post-operative quadriceps atrophy, for example, can all disrupt normal patellofemoral mechanics and contribute to microtrauma. Iatrogenic factors also matter here, so repeated intra-articular corticosteroid injections or exposure to chondrotoxic local anesthetics, such as may occur in professional athletes, can all impair cartilage health. And subtle recurrent patellar subluxation, even without full dislocation, is another common but often underappreciated contributor. Now, to understand how CMP progresses, it does help to revisit the biology of hyaline cartilage. So chondrocytes, the primary cells within cartilage, reside in a specialized matrix composed of type 2 collagen and proteoglycans. Nutrients reach them through diffusion because there's no blood supply, no lymphatic system, and no neural network in the cartilage. And this avascular nature is partly why cartilage repairs poorly, and why, once deterioration begins, it can be quite challenging to reverse. Mechanical stress and aging both impair cartilage resilience. As with age, chondrocyte numbers drop, proteoglycan content diminishes, and water content falls, all leading to stiffer and more brittle cartilage. Now, while the cartilage itself can't generate pain, surrounding structures, such as the anterior fat pad, joint capsule, and occasionally the subchondral bone, can produce the discomfort that our patients feel. Histologically, cartilage is organized into 4 layers. The superficial zone offers a smooth, gliding surface, whilst deeper layers resist shear and compression, and the calcified zone anchors the cartilage to bone. Now, CMP begins at the surface and then slowly works inward as degeneration progresses. Now, as we all know, clinically, patients often arrive in our surgeries complaining of anterior knee pain, which is often vague and difficult to pinpoint. They may describe pain whilst descending stairs, or pain on squatting, kneeling, running, or even just sitting for long periods. And this is sometimes called theatre pain because of the symptoms being triggered on walking after sitting for some time in a cinema or theatre. They may also note occasional swelling, some quadriceps weakness, or a sensation of grinding behind the patella, but none of these findings alone clinches the diagnosis. For that reason, a thorough history and physical examination is essential here. So, during examination, pay attention to limb alignment, quadriceps bulk, hip and core strength, patellar mobility, and tracking throughout the range of motions. Signs such as a lateral patellar subluxation, decreased medial glide, or a positive apprehension test may all point towards maltracking being present. And you might recall Clark's test, where the examiner applies inferior pressure on the patella as the patient contracts the quadriceps, and this may reproduce symptoms, though its diagnostic value still remains imperfect. Now, in terms of diagnostic imaging, and a really important point here is that CMP is often viewed as a diagnosis that is made on imaging. Plain radiographs are generally unremarkable in the early stages, but do become more informative as the structural changes accumulate. CT scans are especially useful when evaluating alignment issues, and MRI is the most valuable non-invasive tool for assessing cartilage integrity, with T2 weighted sequences in particular revealing increased signal in softened cartilage. An MRI scan can also help to assess patellar tilt, trochlear shape, patellar height, and tibial slope. And increasingly, recent MRI studies have demonstrated a relationship between increased subcutaneous knee fat thickness and both the presence and severity of CMP, particularly in female patients. Arthroscopy remains the most precise method for direct evaluation, although its invasive nature reserves it mainly for cases where imaging is inconclusive or when surgical treatment is planned. Now, management usually begins with a long course of conservative therapy, typically for up to a year, before any surgical intervention is considered. And the foundation of treatment here consists of activity modification, non-steroidal anti-inflammatories as needed, and a structured program of rehabilitation. Physical therapy is especially important, with an emphasis on closed chain strengthening, rebalancing the quadriceps, and improving hip and core strength. Foot orthosis may help when excessive pronation contributes to the problem, and bracing, taping, and other adjunctive measures can be used, although their effectiveness does vary from patient to patient. Now, biologic treatments such as platelet-rich plasma have attracted a lot of attention in recent years, but these remain inconsistent in outcomes at present and so aren't considered standard care just yet. Now, if symptoms persist despite this dedicated conservative management, then surgery may be considered. And the choice of procedure does depend heavily on the patient's age, anatomical features, and the extent of the cartilage damage. Options range from arthroscopic debridement or drilling of cartilage lesions to procedures that address maltracking through soft tissue balancing or bony realignment. A commonly employed strategy here is medialization of the patellar tendon combined with a lateral release and reinforcement of the medial quadriceps expansion, especially when maltracking is the dominant issue. Now, chondromalacia patella may be reversible, or it can progress to the development of patellofemoral osteoarthritis. But patients with knee pain resulting from CMP fortunately do often achieve a full recovery, and depending on the case, this recovery can occur in as little as a month or take a number of years. But teenagers often achieve long-term recovery because their bones are still growing and their symptoms generally ameliorate after reaching adulthood. So just to summarize here, chondromalacia patella is a complex, multifactorial condition rooted in altered joint mechanics, muscular imbalances, and cartilage vulnerability. Successful treatment relies on accurate identification of the contributing factors and a structured approach that always begins with non-operative management. Understanding the intricate biomechanics of the patellofemoral joint is essential not only for diagnosing CMP, but also for guiding patients towards the most appropriate and effective treatment pathways. So I hope you found this podcast on CMP helpful, but do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. We do like to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of all our patients in primary care. But as always, until the next time, thank you for listening and goodbye.